Good morning, my name is Second Lieutenant Humphrey. Lieutenant Carlson and I are going to be presenting our physical agents evidence-based review. For our evidence-based review, we started with a PICO question. Our patient for this situation was patients who are recovering from ACL intervention. Our intervention was neuromuscular electrical stimulation along with exercise. The comparison was exercise alone versus a comparative treatment. And then our outcome was knee extension strength and patient-oriented outcomes. So our overall question was, in a patient recovering from ACL reconstruction, what is the effect of neuromuscular electrical stimulation with exercise upon knee extension strength and patient-oriented outcomes versus exercise alone or another comparative treatment? So the evidence our sources that we used to find our evidence, we searched PubMed, Physiotherapy Evidence Database, and Google Scholar. Some of our search terms were neuromuscular ACLr for ACL reconstruction, neuromuscular electrical stimulation, ACL, ACL rehab, and a few others that are listed here. We began our search by limiting our date of articles from 2010 to present to try and find the most relevant and recent articles. However, we found that there were limited randomized controlled trials during this time period, but numerous systematic reviews. So we expanded our search some a few years back and found more randomized controlled trials, which were useful for our research presentation. So an overview of the patient population that we're looking at, like I said, it's ACL patients who just underwent arthroscopic reconstruction. So post-op of ACL reconstruction, it is very common for athletes or for patients to have muscle atrophy, weakness, and a decreased amount of knee function post-surgery. This weakness is really a bad thing because a decrease in quadriceps strength of greater than 80% of the contralateral knee showed in this study done by Lewick for knee kinematics that are the same as a patient who has an ACL deficient knee. So even though the knee has been repaired and the ACL has been fixed, the patient still has kinematics that are just as if they didn't have their ACL altogether, which are shown in these graphs here. But when the patient gained strength of 90% of the other leg, their kinematics were the same as a healthy knee. This just shows that we really need to figure out a way to get back quadriceps strength post-ACL surgery. So a theory that has come up is arthrogenic inhibition as the reason for why patients aren't able to get back that quad function right after surgery fairly quickly. So a definition of this is it's a neural inhibition that prevents the quadriceps from firing adequately. It is theorized that this can be caused by articular swelling, inflammation, pain. It alters the ability of the receptors within the joint to communicate up to the brain, and if it's not addressed, it can cause some long-term strength deficits, which can increase the risk of injury, delay rehab, and also decrease functional outcomes. So neuromuscular electrical stim, which is also called NMES, it is thought to aid in restoring quadriceps strength by stimulating the motor axons of the femoral nerve. A big thing here is that patients can feel the muscle contract, see the muscle contract, and contract along with it, which can help with the whole motor learning aspect of it. So this is performed with 2 electrodes typically placed along the quadricep muscle, and the intensity is turned up until the muscle achieves more of a tetanic contraction where you aren't seeing the fasciculations with the contraction. So now we looked into the literature to see is NMES a good intervention to use on patients post-ACL reconstruction to regain strength and then patient-oriented outcomes. So the first article that we're going to look at is a randomized control trial. It was done by Snyder and Mackler in 1995 on the strength of the quadriceps femoris muscle and functional recovery post a reconstruction of the ACL. It was a prospective randomized control trial on 110 patients within 2 weeks of having surgery. So those patients were randomized into 4 treatment groups. The first treatment group received high-intensity neuromuscular electrical stim. The second received low-intensity neuromuscular electrical stim. The third received a high-intensity volitional exercises, which didn't involve electrical stim, but just involved contraction of your quadricep. And the last group received a combined protocol of the high-intensity and then a low-intensity treatment, which was a take-home device that was battery-operated. All four of these groups also received the exact same rehabilitation protocol throughout the time. So their results found that the high-intensity neuromuscular electrical stim had a 70% recovery of quadricep strength within 6 weeks, whereas the low-intensity only received a 51% recovery in 6 weeks. This shows that the high-intensity was favored in this study. They also found that there was no statistical difference between the high-intensity and the combined neuromuscular electrical stim, so this was interpreted as the low-intensity at-home program wasn't really necessary in order to get the gains that you want. So as far as like money goes and time, trying to save time by sending the patients home with a low-intensity treatment, it isn't really a take-home thing that they found was effective. The next randomized controlled trial that we found was done in 2013, and this was done on professional soccer players who had just undergone ACL reconstruction. This study was interesting because it took the 81 professional soccer players and they had them go through a 6-month rehab protocol before even dividing them up into a neuromuscular electrical stim group plus exercise and just an exercise control group. This was interesting because a lot of the protocols that we've looked at showed doing neuromuscular electrical stim like 3 days after surgery. So their delay of 6 months was definitely interesting. Their dependent variable they were looking at was quadricep strength, and their results at the 7-month comparison, so they did the 6 months of exercise and treatment, and then did a month where the neuromuscular electrical stim people got the stimulation treatment, which was 3 times a day for 30 minutes for each session, 3 days per week for a month. And they did find a significant knee extension difference with a p-value of 0.002 and a 95% confidence interval. Our biggest critique on this article was that it's kind of odd that they waited 6 months to do the neuromuscular electrical stim, and most of the subjects, they were all professional soccer players, had already returned to playing before they even started the protocol. Now Lieutenant Carlson will continue with our literature review.
All right, so for the next article that we reviewed, we have a case control study looking at 36 post-ACLr subjects without a previous history of ACLr surgery. So that was kind of the inclusion criteria. Couldn't have any other previous knee surgeries in that injured leg. They have 4 groups. What they ended up doing is not randomizing them, but they put them into 4 groups. You have your NMES plus eccentric exercise. You have your just NMES alone, eccentrics, and then your standard treatment. One thing they didn't do is actually break down the particulars of that standard treatment. They also had, which I found fairly interesting, is that 10 healthy subjects without any injury, without 10 guys straight off the street sort of deal, and then compared these groups with them as well, so that you had a comparison of somebody who didn't have an injured ACL. They were assessed at pre-op, so right before their surgery at 12 weeks, and then they were tested again at return to play. And they didn't delineate at what point in time that return to play was, which kind of leads me to think that it was a kind of more variable and individual based on when they returned to sport or activity. The NMES treatment that was conducted was only conducted during the 0 to 6 week phase throughout the trial, and then all the eccentric exercises took place during the 6 week to 12 week. So those who received only eccentrics only didn't have that intervention during the 0 to 6 week period. So the NMES that they used, duty cycle, 10 on, 50 off, 2 days for 6 weeks, and then the eccentrics, 2 days for 6 weeks, 4 sets of 10 at 60% of their max eccentric phase for the leg press, and every week they would do it based off of what they were able to do the previous week, and so they were 60% of their max. Results, eccentric only compared, eccentric only and combined treatment. So those compared with the other interventions appear to produce clinical and significant differences. However, no clinical meaningful difference between the eccentric and combined. We kind of looked at it as that being predominance because it was a small sample size. They only had about 8 folks per group, so had they bumped that up, increased their power, they may or may not have been able to determine whether or not there's a difference between the eccentrics and the combined intervention. This was from Lepley in 2014, so it's a fairly recent case study, but it's, as we said, not randomized, which would have provided a little bit better clinical relevance. Here you can see this is an image of how they measured the muscle strength in the quadriceps, and then here kind of another critique is, as you can see, it's not utilized, or it's not readily available clinical tool. So you can see it's a large machine, fairly costly, not going to be very effective within a military clinic environment. Moving on to our next one, Kim et al. Systematic Review 2010. What they did is they compiled RCTs from 1966 to 2008. So they were able to compile numerous articles, scaling it down with their inclusion-exclusion criteria. They ended up coming up with 8 to meet their criteria. However, the Pedro scale on average was a 4 out of 10. And the main point here, we're comparing the effect size between the RCTs. Some of the findings, you have treatment times varied from 30 minutes to 10 hours a day. So you have a very large variability within just standard treatment size, or treatment time, excuse me. Functional outcomes, unclear. You've got only one RCT reporting with the functional outcomes, but the self-reported outcomes, and they're producing moderate effects, but that one had a Pedro scale of 6 out of 10, so a little bit higher quality, but still not a high-tier study. Okay, you kind of have the breakdown, so you can see the point estimates generally here, favoring the NMES treatment. However, you have a large number of the confidence intervals, including 0, potential for there being no significant difference. However, kind of a trend leaning towards favoring the NMES treatment. The next article we have Labrador in 2012. So this is kind of an interesting article that we had found because it's a systematic review of systematic reviews. So they kind of compiled the current literature of all the systematic reviews because there was an abundance of them all looking at various topics, and so their inclusion criteria was fairly broad, so they wanted to pull all of that information in. So we have it had to be a systematic review written in English, and it had to be compared to a standard treatment. So whatever intervention they chose compared to what you normally would do. And then it had to be any sort of physical therapy treatment. Exclusion, multiple reconstructive surgeries. If you had meniscal pathology going along with it, if you had the PCL involved, they wanted to look specifically at the ACL. They initially pulled up 37 systematic reviews, 5 met all the criteria to be included. So it didn't specifically direct all of their focus on the NMES treatment, but what they looked at. And so we were able to see various other means of treating the ACL post-surgery. And you were able to kind of see, hey, we have substantial evidence to look at bracing, the continuous passive motion. You have home and in-clinic treatment, open versus closed kinetic chain. But kind of as they state in their article, there's consistency and limiting evidence for the use of NMES. There's really hardly any good, high-quality evidence out there to suggest that the NMES with eccentric exercise combined is effective or isn't effective. So that was just kind of a point that the systematic review was making, is that more research is needed because they didn't even feel comfortable enough to make a solid stance within their article, whether or not it favors it or does not. So looking at our safety, effectiveness, cost, and patient tolerability. Is it safe? We said it's safe as long as it's performed by a trained provider. Effectiveness, questionable, as we've seen. There's limiting evidence to support it. The cost, outside of your regular exercise equipment, so we kind of seen a trend that the eccentric exercise, or just exercise in general, promoting that quad development is beneficial. So outside of just what you would need to normally do that, you've got $10 to $12 for a 4-pack of pads, plus the one-time cost of the machine and the occasional batteries, if if it's not a wall outlet. So you have patient tolerability. We said it's tolerable to moderately tolerable and highly dependent on the voltage that's applied. And then, as we said earlier, if the patient co-activates along with the contraction or with the electrical stimulation, it's theorized to be less painful, more tolerable for the patient, which was seen in the previous studies discussed. So conclusions and clinical applications. So kind of as we've been describing throughout this, lacking high-quality RCTs, heeding the advice of the numerous systematic reviews. We have a lot of systematic reviews that are out, but we're not going along and seeing what they said and kind of taking that advice, taking that input, and creating better high-quality articles or RCTs to address the lack of evidence. And it's mixed and inconsistent because we don't have a application process that is very rigid and set. So they're all using kind of different parameters. So kind of what the systematic reviews are saying is that we need to have set parameters and see which of these set parameters is going to be more beneficial. And then we kind of conclude here with NMES and exercise. It doesn't appear to be any less effective than exercise alone, but we can't say that it is more effective than exercise alone. As you can see here, these are our references.
And then if you have any questions, feel free to contact us. Thank you.